Thank you so much, everybody, for joining us during your lunch hour today. We have a wonderful session here uh, for injury prevention. And if you are training for an endurance sport or preparing for the Seattle Marathon, half or full, we got a fully baked session here. Randy Gladwish is a physical therapist at the UW Sports Medicine Center at Husky Stadium here, and with over 20 years of experience working with outpatient orthopedics. Um, he has a wealth of information to share with you today. But before we get started too far in, I want to mention that if you have any questions, please feel free to use the chat or the Q&A function to answer. We'll probably have some time at the end for Q&A. And as always, this session is being recorded. If you have to jump off, I'll be sending a recording following this session. But without further ado, Randy, I'll have you take it away.
Okay, thank you, Sebastian. I'll be talking about running injuries, prevention, and intervention today. So I have no disclosures to declare. Some common types of, some things on the agenda for today will be common types of running injuries, running mechanics, common causes of running injuries and risk factors, treatments of common running injuries, running shoe selection. I'll be discussing what tissue stress is and also the difference between tendinopathy of a tendinitis versus a tendinosis. So common running injuries. We won't discuss all of these, but we'll discuss some of them. But here's a pretty long list of them. Hopefully it doesn't make you paranoid. Medial tibial stress syndrome or shin splints, Achilles tendinopathy, plantar fasciitis or plantar fasciosis, patellofemoral pain syndrome, iliotibial band syndrome, high hamstring tendinopathy, trochanteric bursitis or trochanteric pain syndrome, low back pain, patellar tendinitis or osis, meniscal injury, stress fractures, post-tibial tendon dysfunction, and first metatarsal phalangeal joint pain. Some common causes or predictors of running injuries are training error, too much too soon, duration or intensity, or frequency changes. Previous injuries, especially when running before you're fully healed, will have an effect on future injuries likely. Overuse, too much load for the tissue's capability to adapt to it in a positive way. Structural issues, the way we are individually designed, or biomechanical issues, the way we move. And then less experienced runners also have a higher risk for injuries. So training error is a common one. The tissue responds to load well if it's given enough time for it to adapt under normal circumstances. If we increase our rate of loading faster than the body can adapt, we will slowly break down the tissue, which may lead to injury. A common rule of thumb for progressing your running load is only increasing your load by 10% per week. And every third week, you take a break from the increase. So you just kind of hold it steady on the third week to give your body even more time to adapt to those increased loads. And you don't want to increase your loads if you're painful during a run until it's no longer painful during the run. If you're painful after a run, unfortunately, you need to decrease the load so it isn't painful after the run. There's just too much inflammatory aspects happening from that, most likely. And you can increase or change one aspect of your run at a time. For example, if you introduce hills, decrease the distance or intensity. If you increase the speed, decrease your duration or your distance. And give the body a chance to adapt after new loads are added to it. So give your body more rest time if you're increasing, or even better, cross-train with swimming, biking, or strength training. And keep in mind the basics as well: good sleep habits, healthy diet, and good hydration. When we look at the running mechanics, we look at two different phases, the stance phase and the swing phase. The stance phase is broken down to three different parts as well, initial contact, mid stance, and toe push off. Here, that's initial contact just as his foot hits the ground. And then when his right foot's underneath him, that's mid stance, and that's toe off there. So those are the three different parts of the stance phase. So the initial contact, here, this runner's a 4-foot striker. You can see in the picture, he's landing on his 4-foot here. He's a little bit plantar flexor. The toes are pointed down in relation to the lower leg, so that gives the ankle a little bit of ability to shock absorb. Also, the knee is fairly bent here, and the hip is fairly bent. So there's pretty good shock absorption through the system here. There is more load going through the foot in this part of the stage for this type of 4-foot striker. A midfoot striker will actually be landing more midfoot. It'll look like he's going to be landing on his heel, but he actually paws back a little bit and he actually lands more midfoot. And with that, you will find that, you're going to back this up a little bit, as he hits here on that's his contact here, you'll see that his knee is straighter than the 4-foot runner and his hip is straighter as well. And his ankle is not, is more of a neutral position than it was for the other runner. A rear foot striker is just as it shows in the picture here. He's hitting his heel first. And if you look at his center of mass coming down his body here, you'll see how his foot is a pretty good distance forward from the center of mass. And here he's going to be hitting at the heel, obviously. The knee is pretty straight, and then the hip is more underneath him as well. So there's less absorption of forces through the joints at the ankle, knee, and hip. And there's a bit of a braking force. When your foot hits out in front of you, it actually stops your momentum briefly, and then you have to get your body to come up over the foot. So some people think this might be a little inefficient. Might be good for certain people, though. So there's no real right type of foot striker. The swing phase is where the leg is moving through space, getting ready for the stance phase. The initial swing is right after the push off, and then the mid swing is the foot's underneath the body, and the terminal swing is when you're preparing to get that initial contact. Here, your hamstrings work pretty hard to decelerate your foot as it's about to hit the ground, or just decelerate your leg. So with sprinters or hurdlers, this is where they get a lot of hamstring injuries in the swing phase, but most of the injuries probably happen during stance phase. So we give most of our attention to the stance phase. And the initial contact is by far the most researched part of the running gait. It has a significant effect on the ground reaction forces. It's more about the rate of forces that we're more interested in. The ground reaction force is how hard we hit the ground or how hard the ground really pushes back on us. This is this idea of the ground reaction forces influence the trend to be less of a heel striker and more of a midfoot to 4-foot strike runner. So then we'll try to discuss here what normal running techniques. I don't really feel like there are normal running techniques. There's odd running techniques for sure that maybe should be addressed, but these are the mechanics that are considered somewhat normal, but rarely do we try to adjust someone's running technique to prevent injuries unless they have a history of a particular injury or their mechanics are very far from normal that might overload certain tissues that they've had trouble with. So we have to kind of look at their problem and look at their running technique and see if we can pull those two things together and reasonably make a cause and effect solution or conclusion from it. Sometimes the odd mechanics are driven from structural issues. Like for example, they're just born with the anatomy of their hips are turned inwards more. So that's a bony situation. If we try to have them have their toes pointing in front of them and not letting them kind of go pigeon-toed, then we're kind of changing stuff that we probably shouldn't change, at least not in physical therapy. These can be addressed in much more invasive ways, but we're not getting into that today. So stress that I've been talking about is pretty much load times intensity. Load could be thought of as distance, and then intensity could be thought of as speed. And tissue needs time to kind of get used to these things. It'll change. Our tissue changes constantly. So we're laying down new tissue and cleaning up old tissue, and the demands we put on it have an effect on what we lay down, we believe. So things we commonly address in physical therapy to improve mechanics, we look for tight structures that might limit more fluid motion or mechanics. We look for weak muscle groups that need to be strengthened, and we also help the patient understand some possible biomechanical issues that they should be aware of. Some common restrictions that may affect your running gait would be a lack of ankle dorsiflexion, or the ankle to be able to come up or your body to come over a fixed foot, or lack of hip extension. Often the hips will get tight and you can't extend your thigh behind your trunk effectively, which will shorten the stride or make an asymmetrical stride, or even put stresses on different parts of the body. The lack of ankle dorsiflexion can influence the joints below it and also the joints above it. So if you are lacking ankle dorsiflexion, you'll probably have to try to get some way to get your body over your foot. So you'll probably end up pushing your arch into pronation, or your foot into pronation, or the arch dropping. And with that, the tibia, their lower leg, will turn inwards, and then the femur will follow that as well. So there's kind of this internal whole rotation of the whole limb. And that can affect the way the kneecap tracks and also loads through the foot, ankle, and knee as well. The lack of hip extension affects the strides. If we really try to get an efficient stride as we walk or run, that's kind of what we do as primates. So if you're lacking hip extension, you're going to get an equal stride potentially, but you're going to go through your lower back to get it. So you'll have to curve your lower back forward more, or there'll be more lumbar rotation for the pelvis to kind of follow the thigh as it goes behind you. You'll cheat to get the symmetrical stride, and that cheating might load those other tissues more than they can tolerate over a period of time. So how to check for ankle mobility? You can put your foot on the floor with no shoe on, maybe get it about 10 centimeters off the floor. You bring your knee towards the wall, and essentially you're trying to see how far you can get your foot from the wall and keep your heel down and have your knee come straight forward over your toes, so you're not going over the arch. Then you could measure one side to the other, and then you could see if there is any kind of asymmetry between the two sides, or if you're way less than 10 centimeters, then you might try to gain some more ankle dorsiflexion to decrease loads in other parts of the body. Here's one way to get the increased dorsiflexion, just a simple heel cord stretch hanging off of a step, or you can do the typical runner stretch where your foot's behind you. With this position, your knee is straight, so you're stretching both the two muscles back there, the gastrocnemius and the lower calf muscle, the soleus, in this position. So this would be a static stretch. You might hold it for a minute, minute and a half, for a few reps to get it to a total of a minute and a half or so. And you can also do this with your back knee bent here. So with the knee bent 30 to 40 degrees, you take the gastrocnemius out of the picture, and you're working more the lower calf muscle or the soleus muscle. When you're in this position, you're either going to feel it behind the lower leg here, or you're going to feel it in front of the ankle. If you feel it in the front of the ankle, that's actually more the joint restricting that motion. And this, you might be more respectful and not lay into it for a minute and a half. You might just do some shorter repetitions, trying to milk a bit more motion out of that joint than just really pushing hard into it. If you feel it behind here, you can lay into that a little bit harder like you typically would a regular static stretch. To stretch your hip into more extension, a half kneeling position works pretty well. In this position, you would try to like flatten your lower back. So you kind of tuck your buttock underneath you. Then you shift your body forward, and you keep your upper body vertical, and you're trying to get a stretch in the front of the hip joint with this. He could have kept a little better pelvic tilt with that stretch, but that is the idea of that. Some common ways we adjust running mechanics in physical therapy is we work with patients' cadence. So if they're a recreational runner and their cadence or steps per minute is significantly less than 160 steps per minute, we might ask them to increase their cadence 5 or 10% at a time. Or we might say, ask them to run softer or quieter. Or we might work on their upper trunk posture or their trunk lean. All these things actually kind of create the same solution. So if you're running at a higher cadence or steps per minute, you're probably taking a shorter stride. You're not hitting the ground as hard in front of you. If you're running softer or quieter, the same thing. You probably won't reach in front of you quite as far and do that hard heel strike. You'll have your feet underneath you more, and you'll probably be leaning forward more to kind of be more towards the forefoot. So there are a couple of different types of bone stress injuries or stress fractures. There's low risk and high risk. The low risk doesn't refer to the less chance of getting this stress fracture. It has to do with like the repercussions of the stress fracture. A high risk stress fracture is worse to have. Often the bone doesn't have much blood supply there, or it might entail more intervention or a surgery or longer period of non-weight bearing or longer time of not running. Hopefully you don't run into those, but this is where we have patients stop running. We try not to ask patients to stop their running. We try to adjust their running loads or their techniques to try to keep them going, because they never want to hear us to say stop running, and they won't listen to us either, most likely. But a bone stress injury is a different situation. So some risk factors for stress fractures are biomechanical issues, where the ground reaction forces are very high or the initial rate of force is very high. Essentially, a heel striker would affect the rate of force going through the lower leg, thigh, and pelvis and low back. A training error would be just too much change in the routine, or too soon or too fast after an injury. Muscle strength and endurance in order to maintain reasonable mechanics. If you don't have the muscle strength, training surfaces or terrain, potentially. If you're running on really hard surfaces, it potentially might be more load than if you're running on softer surfaces or running downhill frequently. Genetics, there's some genetic situations where you would be at a higher risk for bone stress injuries as well. Diet and nutrition, we'll talk briefly about relative energy deficiency in sports, or REDS. Bone diseases, diabetes, autoimmune diseases, osteoporosis, and thyroid disease can all have an effect on bone density and have an effect on the chance for getting a stress fracture. And some medications like glucocorticoids or prednisone or anticonvulsants can also increase the risk for stress fractures as well. The REDS, the relative energy deficiency in sport, it's essentially disordered eating, not enough eating for your activity level. So you're going to calorie, depletion. Some signs of it would be some menstrual irregularities, missing or irregular periods, bone loss, premature osteoporosis, and athletes in weight-focused sports are at a higher risk for having REDS. So if you have a history of stress fractures or medial tibial stress syndrome, some things we might do in therapy, we would consider increasing their cadence by 5 to 10%, especially if you're below the 160 steps per minute. Consider running softer or more quietly. After passing a return to run program, try to have at least 2 days of recovery between runs to let the osteoblasts come in more and help develop new bone. So the second day they find of rest, it makes a significant difference with the bone stress fractures or recovering from them. Consider more mid to forefoot running potentially if it's a tibial stress fracture or stress fractures above the leg as well. That'll decrease that initial rate of impact of forces. And consider running uphill to decrease the initial impact. Especially if you have a hard time with the forefoot running, the running uphill will kind of force you to get more of the ankle into the picture as well, and the knee will be more bent as you're going up the hill. You might have to walk the downhills in that situation though. And the bone stress injury requires rest time, unfortunately, and some unloading And this will vary depending on the risk level of that bone stress injury. This is an example of our UW return to run program that we use. There are a lot of running programs out there, and most of them are going to be just fine. The most important thing is that it's a methodical increase in the running, and then a methodical decrease in the walking, and until you can kind of tie the two together where you're doing continuous running. The main points to kind of keep in mind in these running programs, if you're at, say, stage 4 here and you're doing 4 repetitions of a 2-minute jog, 1-minute walk, and you have more pain after that run, you'll have to move back a stage and continue back into the stage 3 in this situation for 2 times and pass it, which means no pain during and after, before you can move back to stage 4. So there's a lot of forward and back going up and down between the stages. But what it does, it keeps you honest in regards to not increasing your load before your body has adapted to it. If you have pain during the run, but no pain after, then you can stay at that stage until it no longer hurts during the run. But if you start getting the pain after, you have to go back and then restart again. So a tendinopathy just means pathology of a tendon. It can often be a tendinitis or a tendinosis. Tendinitis will involve inflammatory aspects, and tendinosis does not involve inflammatory aspects. This is why, like a tennis elbow, it doesn't respond well to ibuprofen or icing. It just doesn't have those inflammatory properties. So here's a histological image of a normal tendon on the left and a tendinosis on the right. On the left side, you can see the fibers here are all kind of lined in the direction of force, and it looks very organized and healthy. In the tendinosis on the right, it looks like someone took a handful of spaghetti and threw it up against the wall. It's very thick and disorganized tissue with a lot of blood vessels in it, which isn't necessarily good. There's a lot of fluid in the matrix of this tissue. So if you see someone with a mid-substance Achilles tendinosis, you'll see a big bump about 2.5 centimeters up from their heel bone. And that'll be really painful for the first steps in the morning, which is often a question we ask when we're trying to figure out what kind of tissue problem they have. And if those first steps are tough and it gets better pretty quickly, we often think of a tendinosis. I think what's happening here is we're moving that fluid within the tissue quickly with that first step in the morning. And then we have that pressure of the hydraulics of that fluid moving through the tissue, and that creates deflection or force on that tissue, creating pain. Some common areas for tendinosis would be up in the back, in the ischial tuberosity or the sits bone, where the hamstring attaches to the pelvis. That can become a very recalcitrant area of the body to treat. It's a tough one. Gluteus medius tendinosis is on the outside of the hip, where that the tendon attaches to the bone on the outside of the hip. The iliotibial band tendinosis would be on the lateral of the knee. A patella tendinosis or a patella tendon tendinosis would be between the kneecap and the tibial tuberosity, kind of the tendon or the patella ligament there. It can also happen in the quadriceps tendon where it attaches to the patella tendon. In the lower leg, on the medial side of the calf, about 5 centimeters up from the inside of the ankle bone, you can have the posterior tibialis tendinosis. This is often where medial tibial stress syndrome can happen here, which might be a bone stress injury or it might be this tendinosis problem. A mid-Achilles tendinosis would be around here, and the insertional Achilles tendinosis would be a little further down, right near the insertion onto the calcaneus or the heel bone. And then the plantar fasciitis or fasciosis would be kind of just in the front side of the heel bone on the arch of the foot. So the Alfredson protocol we use for Achilles tendinosis, it came out in 1998, and it was kind of a big game changer. We would often rest these painful areas, and then they would feel better, and then they start their activity again, and they'd hurt again. And they just really didn't improve very well. And Alfredson decided to load it, and he would load it with eccentrics, which are negatives. So for like an Achilles eccentric would be going up on your toes and slowly lowering yourself back down where the muscle's lengthening while it's contracting. So he would have people do these eccentrics. And for instance, a mid-substance Achilles tendinosis, it would be through a full range of motion. So they would be up on a step and they'd be going down very slowly for 4 or 5 seconds. And they do 3 sets of 15 with their knee straight, and then 3 sets of 15 with their knee bent, and they do that twice a day. That is 180 reps of heel raises in a day for a painful Achilles. What tendinosis really doesn't like is stretching. So unfortunately, sometimes people, they do the loading protocol, like the Alfredson protocol, but they're also doing the stretching. So I'd highly recommend not stretching, especially in the beginning of this protocol. Give the chance for the loading to take effect before you do a lot of the stretching. And then the insertional Achilles tendinopathy, or even the high hamstring tendinopathy, where the bad part of the tendon is right at the edge of the bone that it goes into. At those areas, you definitely don't want to stretch, and you don't want to load into a stretch position for those either. The tendon wraps around the edge of the bone and kind of squeegees out the extra blood supply to it and puts too much stress on that part of the damaged tissue. So there we might work in isometrics or in a more neutral position so that tendon is not stretched over the bone. I'll give you some examples of this as well. So this is for a mid-substance Achilles tendinosis. You can do a eccentric lowering off the edge of the step. He could have a little bit more of that foot off the step, so there's more leverage. He'll lift himself up easily with the opposite side and then slowly go down again with the right side. You do that also with the knee flexed, so you can get that soleus muscle we talked about before. And here he's going to drop down as far as he can, but being that he's a 16-year-old, he's super tight, and he doesn't drop down past the height of the step here, but he would try to go as far as he can for the mid-substance Achilles tendinosis. For the insertional Achilles tendinosis, where it goes into the bone, you would only drop down to the height of the step, or even better yet, you might just do this off the floor and then do the eccentrics that way. We find that it doesn't make a difference too much if it's eccentrics or an isometric where you just hold a certain position, or if it's a slow concentric. The idea is just heavy, slow load. And when it can tolerate this without too much pain, then you would add load to the body. You'd add a weighted vest or a kettlebell to add more weight to it. And it's okay to have pain during this. You just don't want more pain after, which includes the next morning. So if you have a 3 or 4 out of 10 pain while you're doing this Alfredson type protocol for a tendinosis, we consider that fine as long as it's tolerable afterwards. It often actually start off painful and then it'll improve as you go. I think because we're moving that fluid around. So a similar pattern of exercises for the high hamstring might be eccentric slider. So when he does this, when he's out in this position with the furthest out, his hip is in a fairly neutral position. And then as he slides out, he's loading that hamstring more and more. So he's not contracting it in a stretched position. Same thing here. His hip is going to be in a neutral position. His knees are bent, and he's going to slowly fall forward while his heels are held down, working those hamstrings extremely hard, but not stretching it at the hamstring origin, at the ischial tuberosity. We don't always shy away from that insertional tendinopathy. Later in the rehab, before you're returning to your sport, you're going to want to work that tendon in an eccentric fashion, like the sport might involve, in the stretch position. So here he's got the hamstring contracting, controlling his drop forward, and he's in the stretch position at the hip for that hamstring tendon. So this would be at the latter stages of the rehab for a high hamstring. Patellar tendinosis is right below the kneecap. That patellar tendon will often get it. So we do like an eccentric loading program here. It's very similar. It's a 4 or 5 second drop on a single leg squat. The heel elevated helps kind of call the quads in a bit more. and he's really trying to load that. The trick is here, if it's a patellofemoral pain, the behind the kneecap pain, this will probably make you worse. So we don't always start at the 3 sets of 15. We try to figure out what load it might be most appropriate for the patient or the position as well. And then we can assess if you're getting more pain behind the kneecap, or if it is pain behind the kneecap doing this, I would expect it to be worse as you go. And if it's a patellar tendinosis, I'd expect it to get better after 3 or 4 reps. It isn't always clear what tissue's involved. Some common biomechanical issues that affect stress on tissues would be one that's researched often is called a valgus collapse. With this motion, the pelvis drops to the side, the femur will internally rotate and cross the body a little bit, and that'll essentially have the tibial external rotate. So there's kind of a big zigzag of the lower extremity while you're doing this. Mostly from not being aware of it or having weak hip abductors and rotators, or just the way you've always moved. So this is a biomechanical issue, and it might make the patient or the person or the runner seem knock-kneed when they're running. You might see their knee collapse to the inside. And that's not a knee stability problem. That's more likely coming up from the hip, controlling the position of the femur. So an example of this is this knee turning inwards and the thigh turns inwards. And you can see how that arch will be dropping most likely because that lower leg will be just driving over the inside of the foot. So often we'll have people try to strengthen the outside of the hip, the abductors and external rotators if they're weak. So this would be like a modified plank with a clamshell. So they'd be using the band to get the resistance. And we might do a monster walk where we have the band above the knees. While they're doing this, the band is trying to pull them inwards. And this helps them kind of understand what they're supposed to do in order to push out against the band to engage the hip abductors and external rotators. I find this works better to have the resistance than me to tell them, don't let your knee turn in, because then they start turning their foot out. They don't really know where to have it originate from, but the band will help kind of cue them for that. So this would be for the stance leg here. So this left works for both actually. So the left is trying to go into abduction and external rotation. And when that happens, that right leg is getting pulled in by the band, and he has to figure out what to do on that right side to stay under control through that motion. This we might use for the gluteal tendinopathy patient as well, trying to put load through those hip abductors. So for work, the hip extensors here, we might do a single leg bridge where he's just trying to drive up with that left hip here. So running shoes, a lot of patients ask me which shoes they should wear for their foot. What are the best running shoes? And the research, unfortunately, unfortunately and fortunately, it dumbs it down a lot. If it's comfortable, it's probably a good shoe for you. It used to be that you'd go in, or still sometimes you go into a shoe store and they look at your foot and your arch drops, so they put you in a really rigid shoe with a bunch of arch support. That might not be the best thing to do. Actually, most likely isn't, especially if it's not a comfortable shoe when you're trying to force it. The shoes should be replaced every 300 to 500 miles or every 4 to 6 months. Even if you're not using them that much, the material, the EVA or the PEBA will kind of harden and lose its properties just with time. So that's kind of an oversimplification, getting a comfortable shoe, but there are a lot of different shoe types to try to find out which is comfortable. So maybe you could have found a more comfortable one. So what you could look at if you have certain problems, you might try a certain type of shoe. For example, if you have a stiff or an arthritic first toe joint or a bunion, you might try a shoe with a significant forefoot rocker where the front of the foot rocks upwards, which I'll show in a minute here. And you might also want a little stiffer shoe. Or if it's a really tough situation, you might have like a carbon fiber insert that's curved to kind of help the body rock over that toe rather than having the toe have to extend so much as you're about to push off in the late stage of the stance. If you have a limited ankle dorsiflexion and you can't get it back from old ankle injuries or just a really tight calf, you can try a shoe with a higher heel and a lower forefront. We call that a heel drop, or a significant drop from front to back, from back to front rather. And that'll give you, put you in a little bit more of a plantar flex position, which gives you more room for the leg to come over the foot. If it's a zero drop shoe, then you're already in neutral, and then when your body comes over, you're dorsiflexing more. Compared if you're jacked up on the heel a little bit, you'll have a little bit more room to come over that foot. If you've had metatarsal stress fractures, you might try a maximum cushion shoe if it's comfortable again. These things are not set and you should do it, but you might try these types of shoes to see if they are more comfortable than some other shoes. If you've had tibia stress fractures or femur stress fractures, you might try a minimalist shoe, which essentially will make you be not as much of a heel striker because it hurts too much to land on your heel. So you might pull back to be more of a midfoot striker or even a forefoot striker. And this will let your ankle come into play more. Your knee will be more bent, so you'll have more absorption of force, or the rate of force at the ankle and the knee and the hip, because those joints will be more bent going up the chain. But maybe it's even better if you used a cushion shoe to absorb some of the force potentially, and you worked on your cadence so you're not as much of a heel striker, so your foot's underneath you more. And you worked on that initial contact position, or running softer or quieter, or those things that we talked about earlier. So maybe it's a combination of the things without having to force yourself into a minimalist shoe. An Achilles tendon pain, you might do that large drop again where the heel is higher than the forefoot, just to take some stretch with the contraction off of that Achilles tendon. So here's a shoe with a bit of a heel drop. It's higher in the heel than in the front of the shoe. This is the forefoot rocker I'm talking about. So as your body comes over the toes here, there won't be as much of a toe break or toe extension happening here because the shoe will absorb some of that force. So those are the aspects of the shoe to consider. For stretching, static stretching has gotten a bad rap over the years. Essentially, you need to have the tissue length to do the sport or the activity you want to do. Otherwise, you're going to cause some trouble in the joints above and below it. So static stretches would be great to do maybe after a run or days you're not running, but maybe not right before you do a run, especially if you're working on speed training. If you're just doing a jog, it's probably totally fine to do static stretch before a run, but you might as well just do the dynamic stretches before a run for a warm-up, like butt kicks or a straight leg march, or bear walks where you're kind of stretching the calf while you're putting a contraction through it. So the idea here is you do a stretch while you're contracting the muscle. You're trying to wake it up a little bit and getting it ready to do deceleration. And those are best right before the activities where you're going to be working at a higher intensity. So kind of to put all this together, a good warm up before your run with a brisk walk or a jog that's lighter than your run. Dynamic stretches are good to do then, or some body weight exercises. Use the 10% rule for running duration and distance changes. So where you're only changing 10% a week, and maybe that third week you give it a little bit of a break, and then you start again every week going up 10%. I'd recommend only changing one variable at a time when you're increasing your load. So if you're going to be working on speed, you probably want to be cut back on the distance you're doing. Consider previous injuries and work on mechanics or strengthening or stretching that may decrease the chances of that re-injury. Cooling down for 3 to 5 minutes after a run would be recommended. And the mind game of, you get busy at work, you couldn't do a couple of runs during the week, and it's the weekend and you got your long run. So you're trying to get so many runs in per week, not doing an extra long run on a Saturday because you couldn't get your weekly runs in earlier. Make sure you don't fall into that trap. So what pain is okay? I mean, if you're a runner, you're kind of okay with a lot of pain. Otherwise, you're probably going to stop running. General muscle soreness is totally fine. Late onset muscle soreness is expected, especially when you're increasing your loads. Slight joint discomfort during or after a workout for a few hours, but fine the next morning, that's probably fine as well. Slight stiffness in the beginning of a run that improves as you go over the first 10 minutes or so, that's probably fine too. What pain needs to be addressed? So pain that's keeping you up at night should be addressed. You shouldn't be increasing loads if your sleep is being affected. There's enough going on that it should be addressed. Pain that worsens as the run progresses, and then you probably would expect more pain afterwards as well. Pain that changes your stride. If you can keep your normal stride because of an injury, that's clearly things need to be addressed or should have already been addressed. And pain the morning after a run, you need to change the loads. So what do you do if you get injured? You can do the typical rest, ice, compression, and elevate, especially if it's an acute injury like an ankle sprain, of course. The tendinosis stuff won't respond well to that. But that's something to consider, especially for an acute injury with the running. Then you want to analyze what you could have done wrong in your training. So did I do a big mileage jump? Did I do a significant pace change? Is the shoe condition reasonable? The type of the shoe, the age, not of the person or the runner, but of the shoe, or is the shoe comfortable? Was this last few runs I did on different terrains, hills up or down, trail running, a camber in the road? Those are things to kind of just look back upon and see what did I do differently that could have helped this not come on if I adjusted for it. And overtraining, some signs of that might be increased fatigue or decreased sleep. And it'd be smart to consider cross training a few days per week with activities like biking or strength training or swimming as well. Try to get those tissues to adapt to different types of activities. I want to thank you for this time with you all and wish you good luck if you're doing the Seattle Marathon and half marathon in a few weeks. Are there any questions?
Wonderful. Thank you so much, Randy. That was such a intriguing presentation. I had so many questions myself, but we also got a few here in the chat that I'll go ahead and ask you if that's all right.
Yeah.
Looks like Cynthia asked, Randy, if you're a new runner, what is considered too much, too soon, and too fast?
So if you're a new runner, there's some great programs out there like the Couch to 5K and things like that. You could look at that, or you can use the Return to Running program that I had in the presentation. It could just be a 1 minute on, 1 minute off. If it's too much, too soon, and too fast if you have significant pain afterwards, especially the next morning. Granted, when you're a new runner, you might get some calf muscle pain or thigh pain, and those are a little bit more reasonable. Those tissues will tolerate the load a little bit better than the tendon pain. There's a lot more blood supply to those tissues than the tendon. So trying to differentiate if it's muscle soreness or tendon or joint pain. The tendon and joint pain, you need to be much more respectful of. So the pain afterwards is you did too much. So not getting emotional with your runs and feeling like it's a good weather day and doing a lot more than you did previously should be helpful in controlling how you progress.
Thank you. Looks like another question here. It's 2 for 1. How do you change your running if you feel like you run in place, like bouncing up and down, rather than forward? And I'll ask you the other one after.
Yeah, so that's a good question. So if you feel like you're going up and down too much, you're probably more likely a forefoot striker, I would think. And probably a good way to do that is try to run quieter, even though you're already a forefoot striker, but you're doing excessive vertical displacement. You need to do some. You need to get some air time, But if you're spending a lot of time in going up and you're less energy going forward, I would think about running a little softer and seeing how that goes for you. And you can also look at your cadence and see what you're doing with that and see if you can make an adjustment. Yeah.
Understood. And before we get into the second one, I believe someone actually also asked another question specifically on how do you run, like running softer and what that actually, I guess, how would you explain that to someone?
Yeah. That's a pretty simple one. So essentially, take out your earbuds and listen to how you're running and the sound of it. And if you just think about going softer, you will. It's a pretty easy, quick change on people. If they're on the treadmill, for example, in my clinic, and they're running, you can really hear them hitting hard. I tell them to go softer, and immediately they make the change. I'm not saying it's going to stick that way because once you start thinking about something else, you'll go back to how you were kind of pounding away at it. The other way is if you don't want to think about it so much, like how to do it, I would go with the cadence. I would figure out what cadence you're running at. So you can use a metronome on your phone and slide it up and down to figure out what pace you're running, or what cadence steps per minute you're running, and then you keep your same speed, and then you dial up your metronome 5 to 10%, and you stay at the same speed of running. So this might be better in a treadmill where you can dial in the speed and then just increase your cadence while you're at that speed, and then get familiar with that. And you'll run softer by increasing your cadence because you're going to shorten your stride and your foot's going to be underneath you more, and it won't be hitting as hard in front of you.
Right. Yeah. Typically, I mean, not exclusively, it might be caused by like heel striking or if you're landing really hard on your entire foot versus, you know, more in that mid or toe, or forefoot running.
Yeah, totally. Yep.
Understood. Thank you. And it actually, my apologies, that actually was the second question. So thank you for answering that one. And the next question I have here is, is it possible that tightness in my calf from cycling is from tendinosis? I guess perhaps this one might be maybe more generally, I guess, tendinosis versus tendinitis. Is inflammation the only way to tell that between the two, which one you might have?
Oh, no, not necessarily. So, I mean, that's with the biopsy, they look for inflammatory markers with that. So, tendinitis, you might see inflamed or thickened tendon, but the tendinosis, it looks like there's like a really significant bump in the middle of your Achilles tendon, about 2.5 centimeters up from your heel bone. If you slide your fingers down that Achilles tendon, just above your heel bone, you'll feel a bump there. And if you squeeze it, it'll be painful. That's most likely a tendinosis. Physicians who do ultrasound can do an ultrasound to image it, and they can see the type of tissue it is as well. If you're feeling it higher up in the calf muscle above the tendon, that's probably more likely muscle strain or tightness in those positions. That's more the meaty area. You wouldn't get a tendinosis up in that section of the calf. It's almost always in that right where it attaches to the heel bone, or about 2.5 centimeters up from there. But you can see it across the room for a tendinosis. And then tendinitis, you rest it for a couple of days, you ice it, and then you're okay. Or a couple of weeks. That's an itis. Osis does not work that way, unfortunately. I've made it maybe seem easy to rehab these. They're not easy. Getting the right load and getting everything else right in the life to make it work or give the best situation to work is really challenging. So by no means that I want it to sound easy. There are other procedures that are done to help with the tendinosis if the loading doesn't work. But the research shows the loading is pretty much as good or better than most of the other ones. They can do nitroglycerin patches over the tendons where they have too much blood supply, which I know that sounds weird. It's just like too much junk is happening in there. or they can do a 10x procedure where they go in and kind of debride with a ultrasonic kind of wand right on the tendon. That's invasive. So there are other things that could be done too, or extracorporeal shockwave therapy, which sounds great. And there's some pretty good research behind that, for the most part. So there are other ways of approaching it too, but this is the first one to try for sure.
Got it. Thanks, Randy. Uh, Looks like next question is a question on soccer. Is shoe replacement time for running, could that be also applied to people playing soccer?
Um, I wouldn't necessarily say that. I think the the biggest thing with the running is the aspects of the shoe. A lot of the cushion and stability of the shoe will degrade pretty quickly from the material. I mean, the foam they use is pretty cool stuff, and they're coming out with even cooler stuff in the last 5 years than the old EVA for those super shoes. Um, but the cleats are different. There's no cushion in them. That's the field you're hoping to get some cushion from. There's grip. So as the uppers break down, or like, if you have kids, they grow out of them really quickly. So checking frequently to make sure they fit. That's probably you're going to change cleats more often for your kids because their shoe size changes than you will probably need to change because the studs wore down. So if the uppers look really worn, or the bottoms are worn out, then that's a good time to replace them.
Understood. Uh, John asks, how much merit do barefoot shoes have in running contexts?
So yeah, the pendulum has been swinging back and forth, hasn't it? So, a few years ago, there's a lot of interest in people wearing, just running barefoot or running in minimalist shoes. Essentially what that did, that took them away from being a heel striker, because you run barefoot, you're not going to land on your heel. That just doesn't feel comfortable. You're going to end up being a midfoot or forefoot striker. So it forces them into that. Whether that's a good way to start a full run, like if you're running, 7 miles, with shoes on, then go into a minimalist shoe or barefoot for 7 miles, that'd be crazy. You're going to end up with calf problems because that just shifts the load. So there's no, you don't go to forefoot running, because that's what you're supposed to do. If you have certain problems, you might go to forefoot running to decrease the load. So if you wanted to train yourself to go into more forefoot running, a minimalist shoe or running barefoot, be one way of doing it. Other ways of doing it are, like we talked earlier, working on cadence, being aware of your contact position, which is pretty easy to do with slow motion video on your iPhone. More of a lean forward, increasing your cadence, running the software will all do those similar things. And maybe you can kind of, do a win-win. Maybe you could have a cushioned shoe and do those other things. But there are some running researchers out there that are totally barefoot running. And you work the intrinsic muscles of your foot more than you would in a rigid shoe. So you get some benefits that way too, I suppose.
Thank you. And we might have covered this a little bit in the presentation, but I think Catherine asked, would you apply the Alfredson protocol for pulled hamstring strain? And how soon after pulling a hamstring should you be stretching versus strengthening, or versus returning to play?
So if there's an acute injury to the hamstring, it kind of depends on the severity of it. So if it's an avulsion where you kind of pull the hamstring off of the ischial tuberosity, for example, and your back of your thigh is black and blue from the hamstring tear, I wouldn't personally start off with stretching that. Essentially, if that hamstring becomes 2 centimeters away from where it should be, I don't want to make you paranoid. You're more likely a surgical candidate to repair it because it might not be able to bridge that gap. But that's not the usual situation. So usually a hamstring tear, you can start contracting it almost right away. You may give it a couple days to kind of settle down a bit, and it can do some light isometrics. I wouldn't be doing the Alfredson protocol where you're doing eccentrics through a lengthened phase right away. That would be closer a few weeks down the road, or at least, at least 10 days down the road where it can tolerate more of a contraction. You're not looking for as much pain when you're rehabbing an acute injury like this than you would a tendinosis. So it's a bit different. Um, but you can start some gentle stretching for a minor hamstring tear, just a couple days after probably, and some light contractions and try to just get things working again. I'd stay away from heavy stretching after a tear.
Thank you, Randy. Um, Couple other questions. I guess someone was curious about what if what about if you have pain, uh, like calf and shin pain one day, but it's fine another day? Is that just probably just general soreness, nothing to worry about?
Yeah, maybe. So if it's after a run and you get calf and shin pain, um, yeah, I think I would look at what you did differently that day, unless, yeah, I would look at what you did differently that day. Was it more mileage? And if you have more calf and shin pain after the more mileage, and it feels like it's kind of the muscle belly area of the calf, then I just kind of chalk that up to that. Maybe you give it a one more rest day and you would not increase your load again. As you would do that same run, or maybe a little bit less that next run, and see if you can get away with it. Until you get away with it totally, then you can increase it again.
Understood. And next question would be, would rowing be a good cross-training option for runners?
Well, you're asking a college rower, a previous college rower. Yes, that'd be great. Um, totally. A lot of hip work, great cardio. Even though, crew race is, 6, 7 minutes in the spring, it's still an endurance sport because of the recovery you get every stroke. Um, so muscle tissue types of rowers is very similar to that of marathon runners. So you get great cardio. It's a different kind of load. You don't have the impact. Loads it through different parts of the body. So yeah, that'd be a great way.
Understood. Uh, yeah, looks like I have three more questions here. It looks like a lot of them are centered around pain and strain, and just kind of, again, I guess just trying to figure out the differences uh, between pain and soreness or aches. Yeah, looks like got a few of them all just kind of centered around that topic.
Yeah.
Uh, yeah, I wonder if maybe perhaps you could speak to, I guess, again, maybe the differences there. When
Yeah.
did,
So, I mean, there's just different intensities, and that's pretty subjective. Um, yeah, the whole pain scale thing is a little tricky because people have different perspectives of what a reasonable pain is compared to another person. Um, I think it's more about the duration of the symptoms in regards to the running. So if you have the same pain coming up time and time again, whenever you try to increase your running load, um, and you have a hard time working around it, I would probably get some help with that. See if you can figure out what you might be able to change, if possible, to help get over that hump. If possible, again. Sometimes tissues just don't have it left in them and they just are maxed out. So if your pain is lasting a long time or continuing on beyond, a day, or the evening of the run, that was clearly too much for you. So you'd have to go back in your training, decrease your load a bit, and then I would try to move forward again. I wouldn't just go back and be afraid to move forward. Go back, do a few more runs where you are fine, and then try to move forward again. You make the tissue couldn't handle it, you go back again. All the time you go back, you're actually working that same tissue, but just not enough to break it down. So hopefully it's adapting histologically to tolerate more load for when you go back again. So there might be a lot of back and forth, but you just have to keep like what you feel like you deserve out of the story. You don't deserve to run further every time. We just don't deserve things like this. You have to go back, do your work, come forward again. If you can progress, fine. If you have to go back again, you do that. And every time you go back, it's still more load. It's not just crossing a threshold where you have more pain afterwards. I guess regarding the aches, yeah, you start a run, you're going to be achy. If it gets better after a few minutes of running, I just kind of ignore it, tell you the truth. If you start worrying about all your aches and pains on the runs, you're probably not going to enjoy running very much.
Thank you so much, Randy. Unfortunately, I think that might be all the time we have. I know there are more questions that we were to ask here, but I guess maybe perhaps we can close off with when would be a good time to perhaps see a physical therapist like you if we had more questions, or should we be concerned, or like when we are concerned?
Yeah, I think if you're struggling with your program where you can advance moving forward, or your stride is changed or it's asymmetrical because of an injury, and then you can't um, get it better, or yeah. So if you have asymmetry during the running, you probably shouldn't be running. So you can kind of work to get some symmetry. So we could help figure out where that asymmetry might be coming from. It's hard to do. The running analysis is it's not a pure science for sure. There are a lot of parts involved with it, and we can't see everything. Um, but if you're struggling with progressing forward with where you want to be with your goals, and adjusting the program where you drop down and move forward again in the loading program isn't working for you, then that's probably a good time to see your doc or see a PT and see if we can kind of help you through that stage.
Thank you. Randy, thank you so much again for being so generous with your time and your sharing your knowledge on all things injury related. Uh, but that is all the time we have. But I will say thank you everybody for joining today's session, and thank you again, Randy. I
Yeah,
hope
thank
everyone
you.
got some value out of that. Um, and yeah, I believe if you are looking for the link, I will be sending out the recording again, like I said earlier, to everybody that has registered to today's session. Um, but yeah, I hope everybody has a wonderful Tuesday.
Great. Thank you,
Thank you.
Sebastian.
Thanks, Randy. Take care, everybody.